good team, but I always support Italy.
Italy is quite good actually.
Yeah,
Nowadays.
yeah, but not like French.
Yeah, France. They are on the league of their own.
France is very strong team.
But I think the Netherlands have a very good chance to win this Euro based on their first performance the other day.
Oh yeah, against.
I think Netherlands is quite strong. Also Belgium starting off strong.
It was very nice game against Ukraine.
Yes.
Yeah, it's very nice.
One of the most exciting game of the opening match of Euro. Very good game.
Very good, yeah. All games are interesting, but the time is not the right time.
Yes.
12, difficult. Difficult to watch. So any others coming or?
I think we can start.
Okay. Just make this one big. Okay, assalamu alaikum and good morning to all of you. So this is our, you can hear me, huh?
Yes, sir. Yes, sir.
So this is our first class on pathology of blood or hemopoietic. I'm not gonna go through the physiology, but I hope you understand what is the blood as a connective tissue consists of cells and the plasma. So you all know that cells are red blood cell, white blood cell, and the platelets. This one you should know, huh? And hemopoiesis, erythropoiesis. So today we will take the red blood cells, RBCs. So what's red blood cell? What's the function of RBC?
Transport oxygen.
Transport oxygen. How red blood cell transport oxygen?
Hemoglobin. Bind to the
by hemoglobin. So in the structure of the red blood cell, you should know the red blood cell is a mature cell, has no nucleus inside, no organelles, but it has a hemoglobin, a protein or large protein called hemoglobin. What's the structure of the hemoglobin?
Heme.
To alpha to beta?
Yeah, from the name, it is heme and globin. So we need the heme and we need globins. Globin is the amino acids. And we need heme. So heme and globin to produce hemoglobin. The heme itself, we need another products. The heme is?
Iron.
Iron, very good. So we need the iron. Iron and protoporphyrin. So iron plus protoporphyrin together will give hemoglobin, heme. The heme combined with the globin to produce the hemoglobin. In the globin chain, we have 4. Each hemoglobin has 4 globins, which is, what's the normal hemoglobin in adults? What's the types of hemoglobin, you know?
HbA.
HbA.
Okay, hemoglobin A.
HB.
A2. HbF. HbF.
HbF plus one more.
B1C.
Hemoglobin A2. This is the 3 hemoglobins, which is a normal hemoglobins located in our red blood cells. But of course, the most common 97% of hemoglobin is hemoglobin A. And this has 4 globins. What is the biochemical structure of hemoglobin A? Alpha 2, beta 2. So we need 2 alpha globins, 2 beta globins together produce hemoglobin A. These structures you should know. Later we see what happened to hemoglobin when alpha is abnormal or beta is abnormal. So the structure is very important. So hemoglobin A is alpha 2 beta 2. 4 globins, 2 alpha, 2 beta. Hemoglobin F is
2 alpha, 2 gamma.
2 alpha, 2 gamma. So alpha always there. Huh? Alpha is not the changing. The beta is the changing. So all hemoglobins, you will find alpha 2. The other one is the changes. So hemoglobin A, alpha 2, beta 2. Hemoglobin F, alpha 2, gamma 2. And hemoglobin A2 is alpha 2, delta 2. So this is the hemoglobin. And to carry oxygen, we need this protein inside the red blood cells. So deficiency of this hemoglobin will lead to a structures called, or disease called, what happens when the hemoglobin is low?
Anemia.
Anemia. So our topic today is anemia. We are talking about the red blood cells. So we take first red blood cell, then we go to white blood cell, then the platelets. So the first 4 classes maybe about the disorders of red blood cells. And the most common is anemia. So when we say anemia, we are talking about the hemoglobin. So anemia by definition is a condition when there is low hemoglobin concentrations. Clear? So when we find the hemoglobin is lower than normal, we say this patient has anemia. So the first thing in anemia, you must know the definition of anemia. Definition is decrease in the level of the hemoglobin in the blood. And because we know that hemoglobin is not the same for all ages, so child is not like adults, male is not like female. So always when you are looking for the hemoglobin, you have to refer the value to the age of the patients and to the sex of the patients. So because female has lower level of hemoglobin than male, it's not the same. So that's why we have different results. So for adult male, if the hemoglobin is lower than 13.5 gram per deciliter, this is anemia. For adult female, 11.5. So the normal figure you should know, huh? The adult male is 13.5 to 16.5 to up to 17, okay. For female, from 11.5 to 15.5. And infant just born, 3 months until puberty, is up to less than 11. We consider it anemia. Just newborn, because newborn need more hemoglobin inside intrauterine. The hemoglobin the concentration is high because they need to carry a lot of oxygen. They are not in the environment where there is enough oxygen. That's why their hemoglobin is very high. So if the newborn, the result is less than 15, is considered anemia. So if it is 15 or above is not anemia. Clear? So again, the definition of anemia is decreased hemoglobin level and not the red blood cell. Huh? Sometimes we have conditions where the hemoglobin is low, but the red blood cell is normal or even higher than normal. So always when you are defining or confirm that this patient has anemia, you must read the hemoglobin. And from where we got the hemoglobin?
Food.
What? How we know that patient has low hemoglobin?
Blood test.
Blood test, complete blood test or complete blood count, CBC. So this is where we can find the hemoglobin. So any patient you want to check the red blood cell conditions, you must do complete blood count, CBC. And this is, you must know what's CBC. Complete blood count means you have to see the red blood cell, the white blood cell, and the platelets. One of the red blood cell, the red blood cell count, and the hemoglobin. So when there is low hemoglobin, first I will go in general aspect of anemia, and then we go to the types of anemia one by one. So this will apply for all types of anemia. Anemia, there are different types, multiple types of anemia. And before we start, anemia is not a diagnosis, it is a condition. So it's a state. So when you find patient with anemia, this is not the end of the story. You have to find the causes of anemia. So anemia can be secondary to many, many things. So first, we know the definition. Again, we refer to the hemoglobin, not to the red blood cells. There are conditions where the hemoglobin is low, but the red blood cell is normal or even higher than normal. Usually, both red blood cell is low, hemoglobin is low, biologically, because hemoglobin is within the red blood cell. But sometimes the content of the red blood cell, the hemoglobin inside the red blood cell, is lower than normal, even though the number is normal. So we check the clinical features. So what happened to the patient when they have anemia? All the clinical feature is related to low oxygen. When there is low hemoglobin, so the oxygen supply to the tissue is reduced. So all our body will have less oxygen supply. And that's why the patient, we have symptoms are non-specific most of the time, like fatigue. When there is less oxygen to the muscle, to the bones, the patient will feel tiredness, weakness, fatigue, headache. When there is decreased blood oxygen supply to the brain, they might feel headache, faintness, confusion, loss of concentrations. Dyspnea for respiratory system, patient will have difficulty in breathing, especially with exertion. Cardiovascular, patient might feel palpitations. Now I ask you why there is palpitation when the patient have anemia.
Heart pump more blood.
Yes, so the heart, this is like a compensatory mechanism. When the hemoglobin is low, the body will feel less oxygen, so the heart will respond to pump faster. So there is increase in the heart rate, tachycardia, which is a signs, but as a symptoms, the patient might feel palpitation, awareness of the heart. So this is a condition, we call it hyperdynamic circulations. The heart will become respond to low oxygen, so they need to push more blood. How to push? The contractility is forced and the frequency is high. So there is tachycardia. Patient with anemia, they have tachycardia. If you measure the pulse, it will be high. Also, there is palpitation. Angina, because of the later on, this is later symptoms. Patient might feel pain on the heart, on the chest, because of less oxygen supply. Signs also, we have non-specific, we have also specific signs. Non-specific means it can be seen in any conditions, not only in anemia. So because of low hemoglobin, patient might look paler, especially in the conjunctiva. As we said, because of hyperdynamic circulation, patient will have tachycardia, increased heart rate if you measure the pulse. Because the heart is pumping faster, they might undergo hypertrophy. So patient might develop cardiomegaly and even heart failure later on. So the response of the heart usually later on. And patient might have systolic murmur, abnormal heart sounds during the systole. Clear, so these are the symptoms and signs of all types of anemia. So whenever there is anemia, patient will have tiredness, weakness, fatigue, headache, palpitation, dyspnea, and they can become paler, tachycardia. There are specific symptoms or signs which can be seen in specific type of anemia. Like for example, if the patient have iron deficiency anemia, we just said iron is very important to produce the heme, which will be used to produce the hemoglobin. So if there is decrease in the iron, there is decrease in the hemoglobin synthesis. And this is the most common type of anemia, iron deficiency anemia. If there is chronic, means long time, there are changes in the skin, in the hair, and in the nails. So in the nail, they might become spoon-shaped. They call it koilonychia. So koilonychia is a specific sign related to iron deficiency anemia. Patient might become jaundice. What is jaundice? What is the definition of jaundice? What is jaundice? Yellow
Yellow.
discoloration of
Very
skin and the mucous membrane due to
accumulation of bilirubin.
bilirubin. So increased concentration, not every yellow, huh? Only when the yellow color is due to bilirubin is called jaundice. If somebody yellow and the bilirubin is normal, this is not jaundice. This is something yellowish because of something else. So jaundice is related to bilirubin. This is also we can see in a specific type of anemia called hemolytic anemia. When there is hemolytic means rupture of red blood cells, destruction of the red blood cell. When the red blood cell is destroyed, hemoglobin is released in the circulation. Hemoglobin outside the red blood cell will dissociate into heme and globin. The heme will produce bilirubin, unconjugated bilirubin. I'm sure you know this one. So jaundice, he's pale and yellow. When you find patient has pallor and he has yellow discoloration, you have to think of hemolytic anemia. Patient might have bone deformities, especially in thalassemia major. And this is because thalassemia major is a genetic disease causing very, very, very severe anemia. The hemoglobin is very, very low. It can reach 4 or 5 grams per deciliter. So why do you think there is bone deformity when there is severe anemia?
Bone marrow cannot produce RBC.
Actually, the opposite.
It tried to compensate.
Yes, the bone marrow is trying to compensate because of very, very severe anemia. So the bone marrow is normal and producing a lot of cells. So this is like hypertrophy of the bone marrow, but we don't use hypertrophy, we use expansion. So there is severe anemia, but not because of the bone marrow failure. It is because of other things outside the bone marrow. This is most likely is hemolytic anemia. The red blood cell is produced normally from the bone marrow, but in the peripheral circulation, it is destroyed very fast. So the bone marrow will respond to produce more red blood cell. So there is increase in the erythropoiesis, very fast erythropoiesis. So when the bone marrow becomes very active, it increases, it expands, especially in certain areas where the hemopoiesis is appear. So normally in adult or in children, what is the bones which produce the blood cells?
In adult or children?
Huh?
In adult.
Yeah, what are adult or children from 7 years, 6 to 7 years above?
Sternum, frontal
Which
bone.
bone? Huh?
Sternum, frontal bone.
Yes, so it's the flat bone or the central skeletal. Not every bone marrow is able to produce the hemopoiesis. It's only because some of the bones are replaced by fat, yellow bone marrow. It's only on the very, very early in the infants, or that's all bone can produce blood cells, but only the flat bones, the skull, the sternum, the ribs, the vertebra, and the pelvis, and the proximal regions of the long bones. So this, because of hyper increase or hyperactivity or erythropoiesis, it might expand and produce bone deformity. So patient with thalassemia major, they might have bruising of the frontal bone and other bones. There are specific type of anemia called sickle cell disease or sickle cell anemia. And this can lead to leg ulceration. In sickle cell disease, we all know the normal red blood cell is a biconcave, flexible cells. So if the patient have this disease, the red blood cell converted to sickle shape, like the sickle. And it becomes and lose its flexibility. It's no more flexible, and it stick to each other. So when it's stuck to each other, it can obstruct the blood vessels and can cause ischemia, and this ischemia can lead to ulcer. So this ulcer is ischemic ulcer due to decreased blood supply. This can be seen in sickle cell anemia. So there are, this is just some of the specific symptoms or specific signs which we can see in specific type of anemia. So like this one is cholinergic spoon-shaped nail because of decreased iron. Iron is used in the enzymes, which is important in the epithelial cells. So when there is a decrease in the iron, in addition to anemia, low hemoglobin, the skin, the hair, the nails also will be affected because of the enzymes used in the regeneration of the epithelial cells. So in general, you can see this is the symptoms of anemia. Every system can be affected, central nervous system. You can go through this one. Huh? What we do when the patient has these symptoms, we have to do history physical examination, as we know, and then you have to identify anemia. How to identify anemia? We just mentioned that.
Complete blood count, CBC.
Complete blood count. So anemia, again, you must look for the hemoglobin. If the hemoglobin is normal, don't mention the term anemia. Anemia, low hemoglobin level. If you find red blood cell is low, hemoglobin is normal, not anemia. So we have to identify anemia by complete blood count, determine the severity of anemia. Severity of anemia can be determined by the reading itself from the CBC, but very important by the clinical features, how patient is looks like. If there is tachycardia, palpitation, heart failure, dyspnea, that is severe anemia. So the patient response to anemia is not the same. Some patients have hemoglobin is 10 and there is a lot of clinical features. Other patient might have 9, but he looks normal. So the severity is determined by the reading itself, by the hemoglobin level, plus more important by the clinical features of the patients. And very important to classify anemia. Classification of anemia, you must know how to classify anemia. So we go one by one. In histology, in the history, there are specific points you have to look for, just very fast. So of course, when there is headache symptoms, you have to ask about onset duration. The background of the patient is very important because there are specific regions in the world where there are more types of anemia, like thalassemia is very common in Southeast Asia. If a child here in Malaysia have anemia, many times you have to think of thalassemia or Mediterranean. So background is very important, like in thalassemia. Past history, past blood transfusion, donation, this one menstrual period, if there is female has anemia, you have to ask about menstruations. Family history, very important because there are some types, few types of anemia which can be inherited, genetic problem, like hemolytic anemia, certain types of autoimmune hemolytic anemia, or there are spherocytosis, and we will see later what are the types of anemia which can be inherited. Thalassemia, sickle cell anemia are inherited disease. So if the patient have history, this can be family history of the disease. Medications, can you give me one medication can cause anemia? Very, very common. Non-steroidal anti-inflammatory drugs. It can cause bleeding. It can cause ulceration in the stomach or in the small intestine, especially in the stomach, can cause bleeding, occult bleeding. It can cause iron deficiency anemia. So medication, very important. You have to ask about non-steroidal anti-inflammatory drugs, aspirin, morphine, and other non-steroidal anti-inflammatory drugs can cause ulcer, and ulcer in the stomach can cause anemia. Of course, diet, especially iron, folic acid, vitamin B12, alcohol consumptions. Physical examinations, you have to look for Baylor, icterus or jaundice. Icterus or jaundice is the same. Glossitis, lymphadenopathy. If you don't have any, if you need any questions, you ask. Lymphadenopathy, tachycardia, hepatosplenomegaly, and petechia. This one on physical examination. The most important is when you find these features, you have to do complete blood count, CBC. And CBC, as we said, we have to define anemia, so confirm that this patient has anemia, identify and determine the severity. So first you have to, hello, are you with me?
Yes.
Yes, doctor.
Complete blood count, look for hemoglobin, hemoglobin lower than normal, confirm that this patient has anemia. From CBC also we can classify the anemia, or we can find the types of anemia. Usually we classify anemia into 3 types. This is based on the complete blood count, CBC. So anemia can be classified as microcytic anemia. Microcytic means that the size of the red blood cell is smaller than normal. So the normal size is 7.5 microgram per diameter, so it might be smaller than normal. This is called microcytic anemia. So microcytic anemia means hemoglobin is low and the red blood cell is lower than normal. Or normocytic anemia or macrocytic anemia. I will ask you, what are the parameters in the CBC which can determine the size of red blood cell? How we know this red blood cell is normal in size or smaller in size or larger in size?
Compared with white blood cell?
No, from the CBC. We are still under complete blood count. So from complete blood count, number 1, you have to say this patient has anemia by looking to the hemoglobin. Again, from the complete blood count, you can say, oh, this patient has microcytic anemia, or normocytic anemia, or macrocytic anemia. So how we can say that?
MCV, mean corpuscular volume.
Was that? Yeah, correct.
MCV means corpuscular volume. MCV.
MCV, yes, MCV. So after you look for the hemoglobin, the next step, you go and check the MCV. This is how in order, how to classify anemia. Number 1, from the CBC, you go check the hemoglobin. If the hemoglobin is lower than normal, okay, this is anemia. Now we want to decide, is it microcytic or normocytic or macrocytic? So the next step, you go check the MCV, main corpuscular volume or main cell volume. MCV is the parameter which give information about the size of the red blood cell. The normal MCV is from 80 to 100. Lower than 80 is microcytic. From 80 to 100 is normocytic. If the MCV is larger than 100, if you find 120, this is called macrocytic anemia. Clear? So this is always like this. You check hemoglobin, next step, check the MCV. There's another, we go later on how we classify. So the first thing from the CBC, identify the anemia and the severity of anemia based on the result. Number 2, classify anemia. Anemia can be microcytic, normocytic, or macrocytic. Next investigations you should do is blood smear, blood film, peripheral blood smear or peripheral blood film. So number 1, CBC, number 2, blood film. Always like that. In every blood disease, you have to order these 2 investigations first. Then you can decide, you can want to do bone marrow or hemoglobin electrophoresis, but the first 2 always like that. CBC, blood film. This is every time. Very easy, very cheap investigations and very fast information. Within 1 hour, you can get the results or less than that. So peripheral blood means you have to do blood smear, and in the blood smear, you have to look for all 3 things, the red blood cell, the white blood cell, and the platelets. So in terms of red blood cell, you have to compare the size. Is it looks normal? Usually the size is very close, almost same like lymphocytes. So if you find lymphocytes, you compare. The shape of the red blood cell, is it looks normal? The number and the color, is it looks pink? And as well as you have to evaluate other cells, the white blood cells. And so you have to remember what to see on the peripheral blood. So like this is the peripheral blood, normal blood smear. So these are all our red blood cells. In the red blood cell, it looks pink in color, and in the center there is white, pale. Normal red blood cell looks paler in the center. You can see that. So there is around 1/3 of the red blood cell is pale because it's concave by concave disc form. So it will not pick up the stain. And this is neutrophil. This is platelets here scattered in between, and this is monocyte. We can see lymphocytes. So this is a normal blood film or blood smear. So here you can see the size looks normal. All the cells are almost the same. The shape is round, biconvex. There is central pillar. So I hope you know that red blood cell. Here. So now we go to classification of anemia. We classify based, so there are many ways how we classify anemia. So maybe we classify based on the causes, the etiology. Etiology or kinetic classification means the etiologic classification, the causes of the anemia. It can be due to inadequate red blood cell production. So means there is decrease in the erythropoiesis. The red blood cell production from the bone marrow is inadequate. And this can be due to bone marrow problem, or maybe the supply. We need iron for the bone marrow to produce red blood cells. So even though the bone marrow is normal, but there is no iron, the hemoglobin cannot be produced. Or if there is bone marrow okay, and the iron is okay, we still need, what other things we need to produce normal red blood cell? So we need normal bone marrow, we need iron. What other things you think we need to produce normal number and shape and function of red blood cell?
B12. Vitamin B12.
Huh? So
Vitamin
we need bone
B12.
marrow, we need iron.
B12.
B12, we need vitamin B12. So if vitamin B12 is decreased, also cannot produce red blood cells. So there is deficiency. What else? Folic acid, we need folic acid. So it cannot be produced if there is no folic acid. So this is in terms of the inadequate red blood cell production. So if the red blood cell production is low, doesn't necessarily mean that the bone marrow is abnormal. The bone marrow can normal, but we don't have normal supply of iron. So this is can cause anemia. Or if there is deficiency of vitamin B12, or there is folic acid and other cobalt and other nutrients we need to produce normal red blood cell. Number two, the causes. The bone marrow can be okay, the supply, iron, vitamin B12, folic acid, everything is okay, and the bone marrow produce normal red blood cell in terms of the function, the shape, and the number. But this red blood cell, after it goes to the peripheral circulation, it's destroyed. There are something can destroy the red blood cell. This is called red blood cell destruction, or hemolytic anemia, lytic of red blood cells. There are so many causes. It can be due to infection, can be due to drugs, can be due to chemicals, can be due to mechanical obstruction, or sometimes autoimmune, the immune system attacking the red blood cells. We will see later what are the causes of hemolytic anemia. So number one in the causes, production is low. Number two is destruction is high, or maybe the blood is lost due to bleeding, anemia, rupture, or accidents. Bleeding can be acute bleeding or chronic bleeding. Acute bleeding usually when there is accidents or injury to the blood vessels. And chronic blood loss is like in case of any example of chronic bleeding means patient
in the stomach.
Yes, GIT, usually from gastrointestinal tract. So usually there is ulceration in the stomach or in the duodenum. This can cause very minimum amount of bleeding, sometimes even unnoticed. We call it occult bleeding. It might go in the stool, but there is no chance. This is after long term, after chronic blood loss, maybe it take years. Patient might develop anemia later on. So chronic blood loss, very common in GIT, especially ulcer, carcinoma. In female also, female reproductive organs can cause some sort of bleeding. And another way how we classify anemia, based on the morphological classification. I just mentioned that based on the MCV. So anemia can be, this is from CBC, complete blood count. We have 1 minute, then we go. So based on MCV can be microcytic, macrocytic, or normocytic. And this is what we are using in the hospital. When you find CBC, when you read it, hemoglobin, then go to MCV. If the hemoglobin is low, MCV is low, you call it microcytic anemia. If the MCV and MCV, by this you can find these classifications which you must memorize. So as we said, we have 3 main types of anemia: microcytic, normocytic, and macrocytic based on MCV. Now we go to another parameters we see is MCH, which is known as main corpuscular.
Hemoglobin.
What's MCH?
Hemoglobin.
You can hear me?
Yes, doctor.
Okay. Who's absent today? Okay, we continue with the, oops. So we just said, can we start again?
Yes, doctor.
Yes,
Okay.
doctor.
So now we are talking about how we classify anemia based on the morphology. This is, we call it morphological classification. Morphological means looking to the size and the shape, especially the color of the red blood cells. The size and the color of the red blood cells. The size and the color, there are 2 things we have to look on under CBC. The MCV, main corpuscular volume. This is to give information about the size of the red blood cells. And we also another, so that in the step number 1, you look for hemoglobin. Hemoglobin is low, we call it anemia. The next step, you check the MCV. MCV is low, we call it microcytic anemia. MCV is normal, normocytic anemia. MCV is large, macrocytic anemia. Large means the normal MCV from 80 to 100 femtoliter, FL, the unit. So if less than 80, for example, 60 or 70, we call it microcytic anemia. If normal, normocytic, and large than, more than 100 is called macrocytic. The third step, step number 3, you look for MCH. MCH is main corpuscular hemoglobin. Main corpuscular hemoglobin means the amount of the hemoglobin inside a single red blood cell. So again, we have a normal figure from 17 to 22 to 29 to 27. If lower than that, the hemoglobin gives the color of the red blood cell. That's why it's pink in color. So the hemoglobin gives the pinkish color of red blood cell. So when the hemoglobin is low, lower than normal, the red blood cell become less pale, less colorful, less pink. And that's why we call it hypochromic. So the first type of anemia is called hypochromic microcytic. So anytime anyone told you hypochromic microcytic anemia, means there are 3 main things. Anemia means hemoglobin is low, microcytic means MCV is low, hypochromic means MCH is low. When you find these 3, this is from the CBC. Always when you read complete blood count regarding red blood cell, check the hemoglobin, check MCV, check the MCH. Of course, you have to check the others, but this is the 3 main things related to anemia. Sometimes we check the hematocrit, the erythrocyte, and the others we will discuss later on the other conditions. But to classify anemia, you look for these 3 things: MCV, MCH, and hemoglobin. The first type of anemia, we call it hypochromic microcytic anemia or microcytic hypochromic anemia. And this is from the name, hemoglobin is low, MCV is low, MCH is low. When you find these three meters, these three things, there are 5 differential diagnoses you must always remember. So the first one is iron deficiency anemia. This is, you have to put number 1 because it's the most common type. Understand? You are following me.
Yes, doctor.
Okay. Hemoglobin is low, MCV is low, MCH is low. This is called hypochromic microcytic anemia. And this is, we have 5 types. Iron deficiency anemia, thalassemia, anemia of chronic disease, some cases, because anemia of chronic disease can also produce normocytic time, but you have to put it in your mind. Sideroblastic anemia and lead poisoning. 5 differential diagnoses. Always remember these 5. This is when you find hypochromic microcytic type of anemia. So if you find CBC is low, hemoglobin is low, MCV is low, MCH is low, what are the next investigations you should order? If I give you CBC now, and you are reading the CBC, you find hemoglobin is low, so it's anemic, and MCV is low, and MCH is low. So what are the investigations you should do?
Blood smear.
Okay, blood smear, you will see the red blood cell looks pale because it's hypochromic. So hypochromic under CBC, MCH under the blood film, you will find pale. The red blood cell becomes more pale. You are right. So we do CBC, blood smear. So you will find the red blood cell looks small and pale. Okay, what's the next very, very important investigations you should always order when you find hypochromic microcytic anemia? Iron. You go and check the iron because this is the most common cause of hypochromic microcytic anemia. We want to find the causes of anemia. So when you find microcytic hypochromic, straight away you check the iron states. So you have to remember, that's why I told you have to remember these 5 differential diagnoses of microcytic hypochromic anemia. When you find hemoglobin is low, MCV is low, MCH is low, in addition to blood smear, you must check the iron, number 1. So your iron, serum iron, total iron binding capacity. If the iron is normal, means it's not iron deficiency anemia. So you already exclude iron deficiency. So if you order iron and iron is normal, what are the next investigations?
Thalassemia.
Yeah, very good. How we classify, how we diagnose thalassemia.
Genetic.
Thalassemia is a problem of hemoglobin synthesis, the globin. So hemoglobin, hemoglobin is heme and the globin. Iron deficiency affected the heme. Thalassemia affected the globin. It is, so we do hemoglobin electrophoresis. For thalassemia, the test is hemoglobin electrophoresis, but we don't do hemoglobin electrophoresis number 1. You must check the iron first. In any case, again I repeat, in any case, when you find hypochromic microcytic type of anemia, next check the iron. If the iron is low, confirm it that this patient has iron deficiency anemia. And next we have to find out why the iron is low. If the iron is okay, everything is okay, the iron in the blood normal, the iron in the bone marrow is normal, so it's not iron deficiency. So the next is thalassemia. Why do hemoglobin electrophoresis? If hemoglobin is okay, we have to check Of course, if the patient have chronic disease, already know chronic disease like rheumatoid arthritis or tuberculosis or chronic infection, or so if the patient sideroblastic anemia is very, very rare type, but we will go later for one by one. Clear? So when we go to second type of anemia is called normochromic normocytic. So what is normochromic normocytic anemia?
Normal RBC, normal level of hemoglobin.
Oh, hemoglobin is low. Once you say anemia means hemoglobin is low. Normocytic, normochromic is not describing the hemoglobin. It is describing the red blood cell, their size and the color of the red blood cell. Understand? So even though the color is normal, normochromic, and normocytic, the red blood cell size is normal, but the hemoglobin is low. So this is called normocytic, normochromic anemia. If the hemoglobin is low, we call it normocytic, normochromic red blood cell. We don't mention anemia. Again, once you say this patient has anemia, means the hemoglobin is lower than normal. This is step number one. Step number two, check MCV. MCV is normal, we call it normocytic anemia. MCH is normal, normochromic, normocytic anemia. Anemia are still there, understand?
Doctor.
Okay, so normochromic, normocytic, this is describing the shape, the color of the red blood cell, but not the hemoglobin concentrations in the whole volume of the blood. So if you find hemoglobin is low, MCV is normal, MCH is normal, this is, we call it normochromic, normocytic anemia. This is usually when there is blood loss, acute bleeding. When there is accident, blood loss, there is no change in the red blood cells, size and shape and color. It's only the amount of the blood is lost. That's why in acute blood loss, usually we find normochromic, normocytic type of anemia. Chronic disease, again, some chronic disease can produce normochromic, some other can produce hypochromic. Post-chemotherapy or hemolytic anemia. So when you find normochromic, normocytic, not all hemolytic, but most of the hemolytic anemia is normochromic, normocytics. So the first thing you should do, if there is no bleeding, of course, if there is bleeding, this is known from the accident, or if the patient has chronic disease, already known. Post-chemotherapy, you know that this patient have chemotherapy or have malignancy. If there is no all these, you have to think of hemolytic anemia. Means there are something causing damage to the red blood cells after it produced from the bone marrow. It's not in the bone marrow, it's in the peripheral blood. Clear? So normochromic, normocytic, think of hemolytic anemia. Of course, the others, but the others by history can figure out if the patient already take chemotherapy, okay, that's we or not. If the patient have malignancy, of course, we know that this patient has malignancy. If there's bleeding, of course, it's obvious there's bleeding. But if there is no other conditions, you have to think of number 4, hemolytic anemia. Again, not all cause of hemolytic anemia, because like thalassemia is hemolytic anemia, but it produces microcytic type. And that's why we said many hemolytic anemias. So not every hemolytic anemias. If you find thalassemia is a type of hemolytic anemia. Clear? Number 3, the type number 3 is called macrocytic anemia. We don't say hypochromic, just macrocytic. So macrocytic anemia means
Everything right.
Hemoglobin is low. Again, once there is anemia, hemoglobin is low. And the MCV is larger than normal. It's more than 100. It's a result from the complete blood count. So if you find this one, you don't think of iron deficiency. Don't go and measure the iron or thalassemia or exclude all the others. When you find MCV is larger than normal, you have to think of folic acid and vitamin B12. This is how you to reach the final diagnosis. So if you find MCV is larger than normal, you don't go and measure the iron because it's wrong. The iron will produce small red blood cell. If the MCV is larger, this is, we call it macrocytic anemia. A macrocytic anemia classified into two types. We call it megaloblastic anemia, non-megaloblastic anemia. This is based on the bone marrow. We have to take bone marrow biopsy and check for the megaloblast. Megaloblast is a type of cells. It is abnormal erythroblast. You know what's erythroblast?
The precursor cell.
Have you taken the erythropoiesis? Erythropoiesis or hemopoiesis, you have already this taken in somewhere.
Yeah.
Yeah.
So we have hemopoietic stem cell, the first one, stem cell, which is, we call it hemopoietic stem cell or pluripotential stem cell, which will produce two types of stem cell, lymphoid and myeloid. Lymphoid still stem cell because it will go and produce lymphocytes, and myeloid produce other types of cells, red blood cell, platelets, neutrophil, basophil, eosinophil, monocytes, all under myeloid. So if you take the erythrocyte, the first cell in the bone marrow after stem cell, which will produce another stem cell called myeloid progenitor, in the line of red blood cell, we have erythroblast, or also known as normoblast. This is the very, very immature stage of the red blood cells. This is the first cell in the bone marrow. It's not anymore stem cell. It only can produce another cell. So this erythroblast, or also sometimes you find it in the books, normoblast, same thing, erythroblast or normoblast. It is the earliest stage of the red blood cell production. And then there's one stage before that, but usually we skip pro-erythroblast, and then erythroblast, then other types of cells until reticulocyte, and then red blood cells. So if there is abnormal, if there is no supply of vitamin B12 or folic acid, this erythroblast becomes abnormal, becomes larger, and the nucleus is larger, and we call it megaloblast. So megaloblast is actually erythroblast, but because there is deficiency of the vitamin B12 and folic acid, this erythroblast becomes abnormally larger than normal, large, and also the nucleus is abnormal, especially the nucleus is abnormal because vitamin B12 needed for the nucleus of the cells. And we call it megaloblast. If there is no vitamin B12 or folic acid is normal, it's called non-megaloblast due to alcoholism, aplastic anemia, liver disease, or hypothyroidism. This one you must know. Huh? This table you must memorize and understand it. Clear? But so the other non-megaloblastic all are by history you can. If the patient taking alcohol, from history you can. If the patient have liver disease, already have chronic liver disease, or hypothyroidism, so we know that. But always, if you find MCV is large, you go and check the what?
Macrocytic.
Vitamin B12. Check the vitamin B12. Maybe vitamin B12 is low, or folic acid. Measure both of them together. So if one of them is low, we confirm that this macrocytic anemia is due to vitamin B12 deficiency or folic acid deficiency. Clear? Understand?
Doctor?
How we classify anemia based on morphology, based on CBC, complete blood count. Hemoglobin, then MCV, then MCH. Three things. You always remember.
Doctor?
We go. Yes?
For macrocytic,
Yes.
you said that all the anemia is HB low, and then for macrocytic, MCV is large than normal. Is there any indication for MCH, whether it's large or normal?
Usually large. Usually increase, but we don't say hypochromic.
Oh, okay.
You just say macrocytic. There is no hypochromic, normochromic only. So just for macrocytic, MCH is usually normal or slightly high, but still hemoglobin is low. So this is called macrocytic anemia. Again, check straight away, look for vitamin B12 and folic acid. Don't go to iron. Here, so the same thing here. This is in the blood, and this is MCV. You can go through this one. The same thing, it's just in the other way. For megaloblastic, we check the bone marrow, but usually we don't need to do the bone marrow. When you find macrocytic, check the vitamin B12 or folic acid. You don't need to go and find the megaloblasts. Usually we don't do. Only in bone marrow, only in very, very complicated case or severe case. So for anemia, usually no need to do bone marrow. Usually only in very, very limited and few numbers of this. So clear, the same thing. So we go one by one. So first, we can hope we can finish this one today. Microcytic hypochromic anemia. So we go first one, hypochromic. Again, anemia means hemoglobin is low. Microcytic means MCH is low, less than 80. FL means Fem 2 liter. MCH is less than from normal from 22 to 27. So picogram, PG is picogram, units you can check in the box. So as we said, when you find microcytic hypochromic anemia, you always remember these 5 things: iron deficiency anemia, thalassemia, anemia of chronic disease, some cases, lead poisoning, or sideroblastic anemia. Clear?
Clear, Doctor.
I always ask this in the questions. I give CBC result, and I told you what do you think, how to classify anemia. So if you find CBC, hemoglobin is low, MCH is low, MCV is low, you say, oh, this is microcytic hypochromic anemia. The next, I usually ask, what are investigations or what are the differential diagnoses? So if I ask for the investigations, again, you must start with iron deficiency because it is the most common cause of anemia and it's the most common cause of microcytic hypochromic. This is how it's produce the microcytic hypochromic. We need iron, we need protoporphyrin to produce the heme, and we need amino acids globin together to produce hemoglobin. So if the iron is abnormal or deficiency, this can cause 2 things: iron deficiency or chronic disease. If the protoporphyrin, this is called sideroblastic anemia. If the globins is the thalassemia. If the alpha globin or beta globin depends. That's why we have alpha thalassemia, beta thalassemia. Clear? So today we go first to the iron deficiency anemia. So iron deficiency anemia, it is the most common cause of anemia and the most common cause of microcytic hypochromic anemia. And when we say microcytic hypochromic anemia, you check all this. All red blood cell indices are reduced. This is from the complete blood count. So again, anemia means hemoglobin is low. MCV, main corpuscular volume, is low. MCH is low. And MCHC is low. Usually we don't go and check MCHC, but if you say it, MCHC is the concentration, is the percentage, the main corpuscular hemoglobin concentration. MCH is main corpuscular hemoglobin, MCHC is the main corpuscular hemoglobin concentrations. So this is the amount, MCH is the amount, MCHC is the percentage. So by percentage, how this amount represent, for example, the amount is 22 picogram, which represent 20% of the content of the red blood cell. This is MCH, MCHC. Clear? If you do blood film, the small red blood cells are small, so it's microcytic, and it's pale, it's hypochromic. Pale means the central paler is larger than normal. Usually the central paler represents 1/3 of the red blood cells. 1/3 of the RBC is white in color. The rest is pink in color. This is a normal red blood cell. If the central paler is larger, almost all the red blood cell is pale or white in color. This is called hypochromic. This is from blood film. Of course, blood film need experience to see many blood films too. But the easy one is to see the CBC. It's just the result, reading. Here, this a little bit on the iron. You already have taken iron under biochemistry or somewhere. Any iron? Okay, physiology have taken iron?
I think biochemistry in the
In other subjects, okay, so at least you know. So iron, we usually take iron from the diet. Only 10% we have taken is, you can read this one, I just go through very fast. 10% of is absorbed. Absorption is increased when there is iron deficiency. Absorption, very important, you must remember duodenum and upper jejunum. This is where we absorb the iron. Iron can be present in different forms. We have ferric iron, we have ferrous iron. When we take iron in the diet, usually it's ferric. We need to convert it to ferrous. Ferrous means F2+, ferric 3+. We usually absorb ferrous iron. Clear? So ferrous iron is absorbed faster than ferric. And how we convert ferric to ferrous? In the stomach, by the acid, by hydrochloric acid. That's why acidity is very important to absorb iron. And that's why if your patient have iron deficiency and you give him iron supplement, you ask him to take iron after food or before food?
Before?
Sibilom makam or sibilas? I don't know how to say it. Before, we know it because we said acidity is important. So you better give iron in fasting state before, because the acidity in the stomach is high before we eat. So iron preparation, pharmacology will explain more. When we give iron supplement, we usually ask the patient to take it before food, not after food, because we need the acidity to convert the acid. You can say favored by factors as acid, which will convert ferric to ferrous, which is absorbed. After absorption, so iron is distributed in the body, the most important hemoglobin. So most of the iron we absorb goes to the hemoglobin. So it goes to the bone marrow. And in the bone marrow, it entered in the red blood cells to produce the hemoglobin. Around 70% of the body iron is present in the hemoglobin. The rest is stored as ferritin or hemosiderin, especially in the liver, in the spleen, which we can use when there is deficiency of the iron. The body can still use the ferritin. Ferritin is the storage form of the iron. You should remember that. Very important in the causes, very important in the diagnosis. Later we will check. So the distribution of iron, mainly in the hemoglobin or stored in the form of ferritin or hemosiderin. There's other locations like myoglobin, the muscle protein also contain iron, and there are so many enzymes which we use the iron, like cytochrome, peroxidase, catalase, heme in the enzymes. This is where we need the iron in our body. You should remember this one. After absorption from the duodenum and upper jejunum, free iron is toxic. So that's why iron is combined to protein called transferrin, produced by the liver. And this transferrin carry the iron mainly to the bone marrow, because we need iron to produce hemoglobin. So they must carry the iron to the bone marrow first, after producing the extra amount, storage as ferritin. Clear? Faham?
Yes, Doctor.
Okay, so after we eat, absorption in the small intestine, in the duodenum, in the blood, absorption means goes to the blood. In the blood, iron is combined to transferrin. Transferrin carry two molecules. Even each one transferrin combined with two iron carry to the erythroblast, to the bone marrow, to be used by erythroblast to produce the hemoglobin. The extra amount stored as ferritin and hemosiderin. So from this physiology a little bit, if we want to say, so if you find, if the patient come to you with headache, weakness, tiredness, he looks pale, and you ask for CBC. And in the CBC, you find hemoglobin is low, MCV is low, MCH is low. So you diagnose, or this type of anemia is hypochromic microcytic anemia or microcytic hypochromic anemia. So the first thing you check of them, I think we don't have time, the iron. What is the causes of iron deficiency?
Diet.
Diet. So that's why we answer, we go through that. So diet, but not nowadays is not a problem. Diet is okay.
Poor absorption.
A malabsorption, yes, very good. So if there is a problem, has malabsorption, especially in the duodenum, jejunum, malabsorption disease, even though you eat. So diet, yes, correct, but very rare. Malabsorption, example of malabsorption, can you give me one disease or two diseases causing malabsorption?
Cancer.
You already have taken GIT, huh? What's malabsorption disorders? One example.
Cancer.
Huh?
Cancer.
Cancer, yes, but not cancer.
Wait, okay. Need to refresh.
Huh?
Need to refresh.
What's that?
We need to refresh first, okay?
Refresh.
Celiac disease.
Huh?
Yeah.
What's that?
Inflammatory.
Yes, inflammatory bowel disease. Especially which one? Which one of them? Which one can go up to the duodenum? What is inflammatory bowel disease? Give me the two examples.
Tropical
Celiac and
tropical spree.
Okay, tropical sprue can cause malabsorption. Very good. This is one, tropical sprue.
Kuat sikit lah ni sebut.
No, you said inflammatory bowel disorders, which is true. What is inflammatory bowel disease?
Crohn's disease.
Crohn's disease and
Ulcerative colitis.
ulcerative colitis. Which one you think can affect the duodenum? Crohn's, yes, because ulcerative colitis only large intestine. It didn't go to the small intestine. Ulcerative colitis affecting only large intestine. It didn't go to the small intestine at all. This is ulcerative colitis. Crohn's disease can affect anything from GIT, from the mouth until the rectum or lower. So any part of GIT can affected by Crohn's disease, but not ulcerative colitis. So Crohn's disease can affect the duodenum, the jejunum, the esophagus, the stomach, and usually present ulceration and can cause malabsorption. So this is the causes of iron deficiency anemia. Most common, always check chronic blood loss. This is number one. The most common cause of iron deficiency anemia, not diet. The diet, I put it the last one, was very rare nowadays. But the most common, chronic blood loss. So when you find iron deficiency anemia, what to do next? Example of, you might do endoscopy. Patient might have ulcer in the stomach. So you can check, especially if they have history of abdominal pain, and so you might do endoscopy to find, sometimes you find ulcer in the stomach. So again, just remember chronic blood loss from GIT, or if the patient is female, reproductive system also can cause bleeding. Number two, increased demands. Increased demands means the patient need more iron, but they didn't take. Example of increased demands?
Exercise.
No.
Pregnancy.
Pregnancy, yes, pregnancy. Patient, when the female is pregnant, they need supplementation. That's why we give iron supplements sometimes because they need more amount of iron. So that's why they have to increase the amount. If they didn't increase, they might develop iron deficiency, or during childhood growth. That's why the nutrition, and very important, malabsorption like celiac disease, chronic disease, tropical sprue, and you can check the malabsorption. Poor diet also can cause iron deficiency. Clinical features, again, can we, I will ask for another session, or we cannot? Cannot.
We have another class at 11.
Okay, no problem. We finish this 5 minutes and then we... general symptoms, as we already mentioned. So there is fatigue, weakness, tiredness, but there are some specific signs and symptoms related to iron deficiency. As I said, iron needed not only for hemoglobin, there are some enzymes which is important in the epithelial cell regenerations. So if there is decrease in the iron, that's why the skin, the hair, the nail will be affected. And we can find some specific symptoms like atrophy of tongue papilla. The tongue become very smooth. This is called the glossitis. Or there is angular stomatitis. The angle of the mouth becomes cracks and painful fissures. This is called angular stomatitis. Brittle nails, spoon-shaped dysphagia, sometimes due to pharyngeal web. This one you can read. So this is glossitis. The tongue lose their papilla. The rough becomes very smooth. So this is atrophy of tongue papilla, is known as glossitis. It's characteristic of iron deficiency anemia. Angular stomatitis, in the angle here, there is painful. Polynychia, this one you should know, spoon-shaped. This is in chronic cause, of course. Lab, again, you have to do CBC. You find everything is low. Blood film, you remember these 5 things: microcytic, hypochromic, poikilocytosis. What's poikilocytosis? Poikilocytosis means there are a variety of shapes. The red blood cell is not looks the same, all of them. So there are variation in the shape of the red blood cell. This is called poikilocytosis. Anisocytosis means variation in the size of the red blood cell. This remember, you always remember, go back and check. Poikilocytosis, variation in the shape of the red blood cell. Anisocytosis, variation in the size of the red blood cell. And you can 5 target cells. Remember these 5 blood film characteristic of iron deficiency anemia. This is, you can see, I already show you the normal blood film. This is abnormal blood film. You can see the red blood cells are smaller. You can compare with the lymphocytes and neutrophil. It's almost the same size, but now it looks very, very small. And it looks pale because the central pallor is increased. So this is microcytic, hypochromic. Not all cells are normal, so it's called anisocytosis, poikilocytosis. And target cell, you know target cells? You know target cell, what that means?
Like a target.
Yeah, there is dot inside. I will give you in the practical session. I will, like this one. I don't know if you can see it. There is in the central pallor, you can find another dot inside. This is called target cells. Anyhow, once you find microcytic hypochromic, the next step is important to measure the iron. So you have to check serum iron and total iron binding capacity and serum ferritin. 3 things: serum iron, total iron binding capacity, serum ferritin. Serum iron, of course, it will be low. Ferritin, the storage form, low. Total iron binding capacity, high. So these are the 3 main things. Serum iron is full or low. Total iron means the transferrin is remain without iron. That's why it's considered high. And the ferritin is the most important because before iron deficiency is developed, the ferritin must be taken. When there is decrease in the iron, we still can use ferritin. So before it's developed, ferritin is taken. Clear? So this is the most important. Bone marrow is not, no need to do that. And we will stop here because I only have 1 minute. Any questions so far?
No, doctor.
No, doctor.
Okay, I'll see you next tomorrow and we will finish this one and other types of anemia.
Okay, doctor.
Okay, I will send you one assignment for hemopoietic regarding blood transfusion.
Okay, doctor.
Today. Okay. Okay,
How to
thank you
do-
very much.
Okay,
Thank you, doctor.
We still have one